Good afternoon, everyone, on this very snowy day. Thank you for joining us. To everyone in the Northeast, I hope you fared well through this storm. My name is Rob Coonan. I'm a partner at Garfunkel Wild. In normal years, I handle finance, real estate, and transactional matters. This year, like many of my colleagues, I've worked with our health systems and senior living clients to navigate a wide array of legal and operational issues arising under COVID. I'm very pleased to be presenting this webinar with my partner, Lourdes Martinez. Lourdes is the co-chair of the firm's compliance and white collar defense practice group and a member of our firm's healthcare practice group. She regularly defends clients in criminal, civil, and regulatory government actions and assists clients in implementing both fraud and abuse and HIPAA compliance programs. We're also extremely excited to be joined by our special guest and a family member of mine, Dr. Lisa Coonan. Dr. Coonan recently founded Health Preparedness Partners after more than 30 years with the CDC. During her time at CDC, Dr. Coonan led the development of national pandemic influenza preparedness and response plans, and she served in leadership positions for multiple national and international emergency responses. Dr. Coonan was one of the architects for developing the CDC's social distancing guidelines in 2007, and she is recognized as an international expert in emergency infectious disease preparedness and response. In January of this year, she was asked by the CDC to provide consultation for their national COVID response, and she provides expert advice to the CDC's incident management leadership. I should say a small disclaimer, although Dr. Coonan has spent 3 decades at the CDC and is presently consulting with them, her guidance today should not be construed as a direct CDC statement or otherwise speaking on behalf of the CDC. These are just her own thoughts and guidance based on her experience. And during today's discussion, if you have any questions for any of us, please enter them into the question window. And to the extent we're able to answer them during our discussion, we'll do so. Otherwise, we will do it at the end with time permitting. So without any further delay, good afternoon, Dr. Coonan and Lourdes. Thank you for being here today.
Thank you so much, Rob. That was a very nice introduction, and I'm really pleased to be here today. And also very excited to talk to you because there's so many things going on the pandemic front. I know that you're tracking that through the media and through your partnerships with others, but there's so many complex issues to discuss. So in today's agenda, my colleagues and I will talk about a pandemic update, ethical, legal, and logistical challenges, resident issues and strategies, as well as healthcare personnel issues and strategies. And I will try to see if I can get the slides going here. There we go. A few acronyms for us to just focus on before we get going, because there's always alphabet soup in all of these presentations. ACIP is the Advisory Committee on Immunization Practices that advises the CDC and the director on recommendations for use of vaccines and related agents. An EUA is an emergency use authorization that is issued by the FDA for a pharmaceutical product or a medical device. HCP, healthcare personnel, all of those folks that are working in your settings. And the Pharmacy Partnership for Long-Term Care program is a new program that CDC has started that will be providing vaccine to long-term care facilities. And we'll talk more about that in a few minutes. So let's just get started with just a really quick overview about the pandemic. Where are we now? And all of you know that we're right in the thick of it. Over 16 million cases in the US, with over 200,000 new cases just in the last 24 hours. Unfortunately, over 300,000 deaths and several thousand new cases in the last 24 hours. And you can see by this graph on the slide that we're going up and up and up. Unfortunately, CDC modelers are worried that we will continue to see an increase in cases all the way through January. And so we have a lot of work to do to control this pandemic. And one of the most important ways to do that is to use a vaccine and social distancing and PPE measures. I just wanted to show this slide because every place is not feeling it all at the same time, but every state and every territory is affected. So before I start talking about our vaccine program, I just want to remind folks that it's very important to be very vigilant during this time. When we start the vaccine program, it's important to keep fastidious infection control policies and programs in place. It's important to report, all deaths and all cases of COVID to state health authorities and to the NHSN. And it's important to communicate with your staff and with your families and residents and partners, because there's so much information that's coming out. It's hard to sort it out. But I'm going to try to go over a few of the major points. First of all, the safety of the COVID vaccine is a top priority. Many people are wondering, how did we get here so fast? Were there corners cut? And I have to say, I've been monitoring this extremely closely, and it is an amazing achievement. The reason why we have vaccines less than a year after this virus was identified is because of the financial backing of the US government for vaccine manufacturing, and the fact that new processes are used to make the vaccine that require much less time than previous ones. We know that the Pfizer vaccine was approved for an EUA use last week. Right now, as we speak, the FDA is meeting to discuss the Moderna mRNA vaccine, and 2 doses of those vaccines will be needed to confer immunity. Right now, CDC is recommending that vaccines be offered primarily to healthcare personnel and residents of long-term care facilities, and that's where distribution is headed right now. There's a very limited supply right now, but we do know that supply will increase over the weeks ahead. It's important to also know that after COVID vaccination, people can have some side effects. Over 50% of people in phase 3 trials have experienced some mild to moderate side effects. I'll talk about that a little bit more. And the US government wants to make sure that cost is not an obstacle to getting vaccinated against COVID-19. Administration costs should be covered by insurers, so there's no out-of-pocket costs for recipients of vaccine.
Dr. Coonan, but before you get off the slide, if I could just ask you a question, because what I hear, and I'm not a doctor, I don't even play one on TV, but what I hear over and over and over again is, I'm not taking that vaccine because it happened just too quickly. Is there anything that can be said to people to give them, people that aren't doctors, to give them comfort in it really was tested, even though they came up with it in less than a year?
Yes, well, a couple of things. First of all, the polling that's been done this week, it shows far more acceptance and potential acceptance of the vaccine than even just a couple of weeks ago, before the FDA's committees and the CDC committees approved it for emergency use. So we're already seeing a lot more interest in the vaccine from people who are now a little bit more reassured because they're seeing that it was approved. And I think it's going to take time. There's always people that are a little cautious and they need to see how things play out. And that's understandable. But this vaccine is a very good safety profile. I've listened to every one of the FDA meetings, ACIP meetings, and heard the evidence and read the science. And it is a rather amazing at what has been accomplished. An MR vaccine is new. It's a new technology, but it's been studied and developed for over a decade. It just hasn't been brought to bear like we have it now. So I think it's going to be very important for nursing home administrators and leaders and public health leaders to educate their audiences about the vaccine, the safety profile. And then we also need to watch and wait and see what happens. We have heard rarely that a few people, less than 5, have had somewhat of an allergic reaction after receiving the vaccine. That is something that everyone is watching very closely. Fortunately, all of those people have recovered well with no issue. And the FDA has also put out guidance to guide people for allergic reactions and prevention of allergic reactions. So I think we're on a good track. You know, when we compare the efficacy of these vaccines, which are over 90% effective in the trials, with other vaccines that are out there, like flu vaccine, it's pretty extraordinary what's been accomplished.
Okay, thank you.
And then finally, and this is a really important piece that I want to leave you with, and that is that, you know, COVID vaccines are a very good way at helping us fight this pandemic, but they're only one of the many important tools that we have in our toolbox. And other measures like wearing masks and PPE in healthcare settings, distancing, hand hygiene, avoiding crowded indoor spaces, making sure that building ventilation is up to speed, and then disinfection and cleaning. All of those things need to remain. It is not going to be the magic bullet that once we have a few drops of vaccine out there that we're in the clear. It's going to take a while for community level immunity to build. And in the meantime, we need to be using every tool in our toolbox. So, like I said, we all know that COVID vaccine is on the way. It's very exciting. The first healthcare personnel got immunized this week, and it is really just a really good sign that we are now starting to see vaccine flowing towards healthcare facilities and towards long-term care facilities starting next week. I just want to point you to the CDC webpage about the pharmacy partnership for long-term care. I know all of you know about that. You've enrolled in it last month or the month before. And this is a very wonderful arrangement between large pharmacies and long-term care facilities to immunize residents of nursing homes and assisted living facilities.
Dr. Coonan, is it too early to ask you if any of the, and if it is, just stop me. Is it too early to ask you if any of the healthcare personnel that got vaccinated this week have had any adverse reactions?
Only one person was reported yesterday after literally hundreds and hundreds of people have been vaccinated. She did seem to show some allergic reaction. Medicine was given and she's recovered just fine. So there was one person.
Okay, thank you.
And that's why the FDA is recommending that people who get immunized do so in a facility that can manage an allergic reaction. And so I think it's really important that the facilities that are working with the pharmacies in the long-term care program talk to the immunizers about who needs to have what on hand, what the pharmacies might be bringing to the clinic site or to the long-term care site versus what is needed from the long-term care facility to have on hand when people are immunized. This is a little bit of a new wrinkle, just kind of came up this week, but I would urge you to have those conversations. And as you know, this program with pharmacies really provides end-to-end management of the vaccination process so that cold chain management, administration of vaccines, the reporting requirements are all handled by the pharmacy, and that really takes a burden off of long-term care facilities. But long-term care facility staff are still going to need to monitor patients for post-vaccination effects. And also, long-term care facility staff who've not received a vaccine in the community or through other employment can also be vaccinated as part of this program. And everyone should be by now in touch with either CVS or Walgreens for administering the vaccine. Just know that the pharmacy is going to be making multiple visits to the facility to provide vaccinations over about a 2-month time period. They'll be making plans to provide 2 doses to each recipient. The Pfizer vaccine and the Moderna vaccine have different time intervals between them, 21 and 28 days apart, respectively. And it's really going to be important that if a new resident is coming into the facility, to see if it's possible to work with the local hospital to see if they can get immunized before they're discharged and placed in your facility, or if people are coming from the community, see if they can get immunized before admission. That won't be possible right now, but soon, in a couple of weeks, it hopefully will be. So I'm going to really emphasize this again, which is that healthcare personnel and residents should continue to follow all of the CDC infection prevention and control recommendations, even if they're vaccinated. That doesn't take all the PPE, the hand hygiene, the distancing off the table. We need to use all the tools in the toolbox. It's important to know also that PCR, nucleic acid, or antigen tests are not affected by vaccination. So if a person's been vaccinated and they are developing symptoms and they need to be tested, if those tests are used, they should not be untowardly affected. And then it's really going to be important the days before people get vaccinated that staff monitor them to use as a baseline. And that baseline will be a source of comparison after they're vaccinated to be able to evaluate if they have any symptoms. Most people develop signs and symptoms, if they're going to develop signs and symptoms, within about 3 days after a vaccination. And that can include fever, fatigue, headache, chills, muscle aches, and joint pain. And most of these symptoms that have been recorded in the clinical trials are mild to moderate in severity. They usually occur after the second dose, more likely than the first, within about 3 days of vaccination, and they usually just spontaneously resolve within a day or so. Now, if someone is having cough, shortness of breath, runny nose, sore throat, or loss of taste or smell, these symptoms are not consistent with post-vaccination symptoms. So those patients will need to be evaluated to see if they're developing COVID.
I just want to ask one question just to make sure that I understood. So thank you. So if I'm a resident and I get vaccinated and I am later showing signs, let's say 2 weeks later, I'm making it up, obviously, I'm showing signs and symptoms of a COVID-19 infection and they do the test, that vaccine that I just took would not affect the test for COVID-19, the PSR. Is that right?
The PCR, correct.
PCR,
yes.
sorry.
Yes, yes,
Okay.
yes. That's right. And remember that protection is not afforded after just one vaccination. That really is going to take 2 vaccinations spaced apart to give people the protection they need. So it could be that somebody was exposed to COVID and is sort of incubating the disease. They get vaccinated. It's just a coincidence they get vaccinated and they could show symptoms. And that's what this next diagram is to really help sort out post-vaccination signs and symptoms in comparison with ones that might be coming from illness versus ones that might be coming from the vaccine. This is going to be a central point of focus for long-term care facilities. So this simple diagram aims to just say that after vaccination, within 3 days, people may or may not have signs and symptoms, especially after the second dose is people more likely to develop signs and symptoms. And then those signs and symptoms either can be related to vaccination or unlikely to be related to vaccination. If they're unlikely to be related to vaccination, different measures and steps are going to be needed. And let me just walk through each one of these in turn. So an overview is that a person who has signs and symptoms after they're vaccinated, it could be mistakenly interpreted as that person's got COVID. And for healthcare personnel, they could be restricted from work unnecessarily. So it's really important to be able to evaluate and manage post-vaccination signs and symptoms to prevent unnecessarily excluding healthcare personnel from work, and also to prevent from inadvertently allowing personnel who may be infected to come to work. And this applies to all the healthcare personnel working in the healthcare setting. Let me get more specific here. So think about, first of all, ways to minimize the impact of post-vaccination symptoms and signs on healthcare staffing. And I know this has probably been discussed a lot, which is trying to schedule vaccination before people have a couple of days off. and during which they wouldn't be required to be at work, and that might be a really good time to have them away from the workplace. So if a person has symptoms while they're away from work, most likely they're going to resolve very, very quickly, and then they can return to work if those signs and symptoms were only related to the vaccine. Also, staggering the delivery of the vaccine in the facility so that not all people in a certain unit are immunized at the same time. Now, people have varying responses to this vaccine. Some have aches and pains, and some feel fatigued or have a headache. Most of these are mild symptoms, but they could be significant enough to make someone not feel well enough to come to work. It's also going to be important to notify people before they're vaccinated to look out for the signs and symptoms after vaccination, and then talk to them about what they need to do in terms of reporting those to the workplace. And it's also going to be important to develop a strategy to assess healthcare providers' symptoms and signs, and really be able to provide testing to them if it's indicated. And then finally, making sure that there's non-punitive sick leave options so that if people are feeling unwell, that they can stay home. They won't be tempted to come to work even if they have symptoms. So these ideas are suggested approaches to evaluating and managing new onset systematic symptoms and signs after vaccination. And all of this information I'm providing to you was provided by CDC on a COCA call, which is a clinician's call, and there's references in my slide deck that you can go to learn more about this. So it's really important to just think about applying an approach where if a person who works for you has symptoms within 3 days of having a immunization, and they don't have any unprotected exposure to SARS-CoV in the previous 4 days, they may not be having COVID. They may be having the results of the vaccination, and each one of these cases needs to be individually assessed. So just to be very specific, anyone who has shortness of breath, cough, runny nose, sore throat, loss of taste or smell, this is not a typical sign or symptom from vaccination. And so the suggested approach by CDC is to exclude them from work pending evaluation, and then the criteria for return to work depends on what you find in that evaluation and if their test is positive. Now, it may be muddy. In other words, it may not be easy to determine this. So a person who gets vaccinated and then has fever, fatigue, headache, chills, myalgia, arthralgia, those are signs and symptoms that can happen after vaccination, but they can also be signs and symptoms of SARS-CoV or another infectious cause. So people who are feeling well enough to willing to work, do not have a fever, and those systematic signs and symptoms are limited to the ones that are on this slide that are more likely to do with vaccination immediately after they were vaccinated. Those are ones who might be considered for returning to work. You need to talk to your medical director to get guidance about this. All right, I know that I'm going deep into this, but it's really new information, and I want to be able to share it with you. So if a person returns to work with those symptoms like headache or muscle pain or aches, but they're not improving, or that those symptoms last longer than 2 days, they need to go home and be evaluated, and testing would be recommended. And then any personnel that have fever should ideally be excluded from work, because you just don't know if that fever is related to a post-vaccination or if they are ill. So that would be the recommendation for anyone who has a fever should be evaluated and possibly tested if that fever doesn't resolve within about 2 days. All right. There's more information posted on CDC's website that explain all of this in detail. Let me also point you to their examples of healthcare personnel are not folks that are just doing direct patient care, but others that have interface with patients at your facility, including dietary, food services staff, and environmental cleaning staff. So now let's turn to immunizing long-term care residents. And these recommendations are going to be very, very similar. So it's really going to be important to evaluate and manage post-vaccination signs and symptoms among the residents, because you need to be able to balance. You don't want to unnecessarily test people and isolate people, but then again, you don't want to inadvertently let residents who are infected transmit disease to others in the facility. So the approaches are very similar, that you're going to be very carefully evaluating any signs and symptoms and within 3 days after vaccination, and vaccination day is day 1. So for 1 through 3 days, and then making sure that you've got a plan in place to deal with folks where you're just not sure if they're infected or just suffering consequences from vaccine. So that we're going to cover the same material that I did for healthcare providers. That is, the signs and symptoms that are unlikely to be related to vaccination include cough, shortness of breath, runny nose, sore throat, and loss of taste or smell. That is not typical for a post-vaccination. And so those patients need to be evaluated. They need to be isolated from others. Healthcare providers in the facility need to be sure they're wearing adequate PPE. And then they also, and this is very important, should not be cohorted with patients who are known to be infected, because you're still sort of sorting it out and trying to ascertain whether they're suffering from post-vaccination symptoms or if they're ill. So they do need to be in a room by themselves while that evaluation is going on.
So can I ask you a question there? Because right now, the cohorting is, we're putting positives with positives, PUIs or people under investigation with people under investigation, and obviously the people who are healthy are staying, where they're staying put. Does this vaccine, in your view, change that type of cohorting that we're doing right now?
I'm thinking that these are now PUIs. These are people who have symptoms. You haven't definitively determined if they're ill or not, and they need to be worked up.
Okay, thank you.
So again, this is the same information I presented before, and you can read it on the slide, that the typical symptoms after COVID vaccination need to be evaluated. And that's why it's important to do a baseline. So if you've got a patient, they're totally no symptoms, they're doing fine, they're stable, and then day 1 or 2 after vaccination, they develop a fever or fatigue or headache. I mean, that's a pretty good indication that that resident probably has symptoms from the vaccination, and they just need to be evaluated. It'd probably be wise to take measures like restricting them to their room and closely monitoring them. And that's what the CDC is recommending. And then it's very important that healthcare personnel caring for these residents after vaccination who have symptoms, as well as all residents that are suspected of being exposed or symptomatic, to wear the recommended PPE. That's going to be very important for many months to come. And if the resident's symptoms resolve within 2 days, then those precautions can be discontinued. But fever, if it continues past 2 days, those people need to be tested and evaluated. And then if there's active transmission in the facility, or if residents have had prolonged close contact with someone who is infected, they should be tested and evaluated. And this is a current recommendation. And again, there's a lot more information in great detail posted on CDC's website, and I urge you to become familiar with it, since this is a wrinkle and a new thing that we haven't discussed before. Also, there are a number of additional resources, more posted every day, and I know these can be made available to you. If you have questions and you need to contact CDC, the 1-800-CDC-INFO is open for people to call and ask questions. If you need to consult with someone at CDC, there's a way to do that. So I just want to stop there and turn it over to you, Lourdes.
Terrific, thank you. Rob, before I start, is there any questions? I'm sorry, I don't see the question pane for Dr. Coonan. We can't hear you, Rob. Okay, since we can't hear Rob, we'll leave the questions till the end. So I think the first thing I want to say is that this is all really good news. And I really do believe, and Dr. Coonan and Rob, if you disagree, this really is the beginning of the end. It doesn't mean that we are at the end, but it's the beginning of the end. And this will be over at some point, and hopefully we will have immunized in a short period of time the most vulnerable people among us. So when we're talking about the resident issues and the strategies, I think we need to first talk about the goals, right? So what is our goal in the nursing home and long-term care? The goal is, number one, to take care of our residents and our employees so that they are safe and they do not get the virus. And number two, to do it in such a way that we are doing it within the tenets of the law and the guidance that we have. And so I think that's kind of the overall picture. And one of the things that you'll see as I go through my slides and as Rob goes through his slides is we don't know exactly how we're supposed to be doing everything at this point. There is still guidance that's going to be issued as we go forward. So what we're saying today is the best we know today, which could certainly change by tomorrow. So that's my disclaimer. And also, if you ask a question and I don't know the answer, I will get back to you. You can email it to me. Those are my two disclaimers.
And I think I'm unmuted now, so we didn't have any questions yet, but if anyone does have questions, feel free to enter them into the question bar.
Oh, thank you. Okay, so this is just a little reminder of the residents' rights. And so what I want to point out here is that just because we're in a pandemic, there has not been any kind of executive order that overrides these residents' rights, right? So the residents have a right to, they have the right to take the vaccine if they want the vaccine. They have the right to refuse the vaccine if they want to refuse the vaccine. So nothing has changed with their rights based on this pandemic. Okay. They also have the right to be informed in advance by the physician, by the practitioners, by, the nursing. They should know what the risks and benefits of taking the vaccine are. Alternatives, if there's alternative treatment options, they can choose not to have the vaccine. So, and as Dr. Coonan said before, if they choose not to have the vaccine, which is completely their right, that does not change the cohorting as we're doing it now. If they had signs and symptoms, then obviously they go with the PUI. If they're positive, they go with the positives. But simply refusing the vaccine does not change the cohorting. And I've gotten that question from a few nursing homes. That's why I wanted to put it out there. Okay. So the EUA, which Dr. Coonan spoke about, does not require the residents, does not require the residents or the staff to have the vaccine. So this right now is purely voluntary on both ends, staff as well as the residents. That will change when I should put it this way, that will potentially change once the vaccine has full approval and it's not emergency approval, okay? Either way, whether the resident consents or whether the resident refuses, it should be documented in the resident's chart. Okay, so what about consent? Okay, so there's a lot, there's nothing specific that says we need to have written consent. That being said, the recommendation is we should have written consent. CVS and Walgreens, they're requiring their own consent document. They also have a document with the risks and benefits, which should be given to all of the residents. We should maintain either the refusal or the consent, and that should be maintained in the residents' records. Okay. So I think we mentioned this before. The EUA requires that the information be given outlining the risks, benefits, side effects of the vaccine prior to the administration. And this kind of goes back to, and I know that we have a lot of residents that may not have capacity, and we're going to talk about that, but for the staff as well as for the residents, they need to be educated on the vaccine, because education obviously leads to making good decisions. So perhaps if we should develop a policy, some kind of short outline of the risks and benefits that is easy to understand and easy to read. If we do that in the nursing homes, that may be very helpful. Okay. Again, if they choose not to have the vaccine, that's absolutely fine. They're allowed to choose not to have the vaccine, but you may want to have them sign something that says that you gave them the risks and benefits, you gave them the opportunity to have the vaccine, and they chose not to have a vaccine. And you may want to get them, the residents, to actually sign that documentation and keep it in the medical record. And all of this, of course, is designed not only to educate the resident and help them to make the right decision, but also to protect the facility for the eventual, complaint, lawsuit, however it is we want to go about that. And with that, I think I am turning it over to Rob.
Thanks, Lourdes. So a question we've been asked, and Dr. Coonan touched on this a bit, is if a person's already had COVID, should they be getting a COVID vaccine? And according to the CDC at this point, there's just not enough information currently available to say if and for how long after infection someone's protected from getting COVID-19 again. So early evidence suggests natural immunity may not last very long, although we've seen other studies that sort of contradict that. So really at this stage, we just need to wait till we have a better understanding of this virus. And until the vaccine is available and ACIP makes recommendations to the CDC on how best to use the vaccines, the CDC can't comment on whether people who had COVID should be getting the vaccine or not. Dr. Coonan, I guess a question, if you don't mind, for you is, I was reading that people who had COVID in the past 90 days may want to wait a bit and put themselves at the back of the queue before getting the vaccine, I guess, to maybe free up because there's limited availability. Have you heard the same thing?
I have, that is sort of the current thinking. And then to add to what you were saying, we don't know how long immunity conferred by the vaccine will last. So we have to get a flu shot every year in order to be protected. We don't have enough information yet to know if this vaccine is going to last or if we're going to have to get boosters. So all of that is still unknown and to be determined.
Can I ask a question too? Sorry, Rob, before you go on.
Of course.
It's also a question for Dr. Coonan. Has, in all of the testing before the vaccine, was there testing on people that had gotten over the coronavirus? Was all of the testing on individuals who were coronavirus free?
Well, they have found that some people did develop coronavirus after the first immunization, but had no symptoms at all. So they didn't even know that they were infected, and then went on to get the second immunization with no problems or consequences. So right now, whether you had COVID or not is not a condition for vaccine. It's recommended for everyone.
Thank you. And I guess while we're asking you questions, do we know, because I've heard a lot of uncertainty, and I think this is important, about, a person who gets the vaccine will develop the immunity against it, but can they still spread the vaccine?
We don't
Could
know.
they still spread the virus, excuse me?
Yeah, we that's a great question, Rob, and that is one we don't know yet.
Okay.
So in the Moderna discussions at the FDA VRBPAC today, they were having some discussion about that, but I don't think it was definitive. So I think that's something that we still need to learn.
Thank you. For the people listening from the state of New York, the Department of Health recommends that residents who've had COVID-19 are advised to get the vaccine so long as they are asymptomatic. Residents that obviously have acute symptoms or are currently in isolation should not be receiving the vaccine at this time. The department also urges long-term care facilities to keep watch on residents for the first 30 minutes after the vaccine is administered for any adverse reactions. Of course, Dr. Coonan identified what those would look like. Specifically, as we saw a couple of cases in the UK and a couple here in the States of anaphylaxis or anaphylactic shock. So the facility should maintain sufficient, whether it's epinephrine or the other appropriate supplies to administer the appropriate interventions. The department also recommends for individuals who've received the first dose through the pharmacy program that if they are discharged before they've received that second dose, the department advises that facilities should track the discharges and schedule a follow-up appointment to ensure that those discharged individuals return for that second dose, because it's not at this point widely available, so the facility will be in the best position to give that second shot. And it really is important, as Dr. Coonan said, that the residents receive 2 shots. So switching gears a little bit, and this is a question we've received as facilities think about administering the vaccine to a resident who's incapacitated or otherwise they're not in a position to give their consent. For those in New York, the Family Healthcare Decisions Act would apply. So in general, this means that if a resident doesn't have a healthcare agent or guardian, obviously if they do, that would be the one who would make that determination for them. And if there's no one really or surrogate really available to make the determination for them, then the decision would really involve whether we consider this a routine medical treatment or a major medical treatment. Very quickly, without getting into too much of the detail, a routine medical treatment is any treatment, service, procedure, diagnosis for physical or mental condition, such as giving someone medication or extracting bodily fluids or dental care. It does not include long-term provision of treatment such as a ventilator or similar tubes, except when it's part of post-op care. And a major medical treatment is any treatment, service, or procedure to diagnose or treat an individual's physical or mental condition, specifically where general anesthesia is used, anything that involves a significant risk, anything that involves significant invasion of bodily integrity, requiring an incision, producing pain, discomfort, debilitation, anything that had physical restraints or psychoactive medications. At this point, because the vaccine has been approved under an emergency use authorization, and we have not heard otherwise from the department, so at this point, we would recommend taking a conservative approach, which means treating the administration of this vaccine as a major medical treatment, at least until there's specific guidance to the contrary. But at this point, that would definitely be the way we would look at it.
And Rob, just to add to that for a second, we know that these questions as to how to deal with incapacitated residents who have no family, which is a decent amount of the population in nursing homes, that has been sent to the Department of Health. However, as of this morning, as of 5 hours ago, there has not been any guidance. So this is really our best guidance to you to protect the nursing home as well as to protect the resident in going forward with the residents who don't have the mental capacity to consent. So go ahead, Rob. Sorry.
Sure, no, of course, thank you. That was a good clarification. So procedures for when major medical treatment is needed. So the attending practitioner must make the recommendation in consultation with the staff directly responsible for the patient's care. And the medical director of the facility or the physician, nurse practitioner, or PA designated by the medical director must independently determine that she or he concurs with the recommendation that's being provided. If the medical director is the patient's attending, then a different nurse practitioner or PA designated by the facility must make this independent determination. And I think, Lourdes, I'll turn it back to you.
Yes, I am up again. So just a few issues that I know you all have questions on, and unfortunately, I don't really have the answers. So visitors, what do we do about visitors? Are they supposed to have the vaccine? What are you going to do with or without, if they tell you they have the vaccine? The bottom line is that right now, there's no guidance on visitors. So whatever visitation, if you're open to visitation right now, I think you continue the open to visitation the way you have it now. If you're closed to visitation right now, then obviously you're going to continue to be closed to visitation. Again, guidance has been asked on all of these questions, and we don't yet have the answers.
One quick question, I guess, for Dr. Koonin. I've been reading a lot and hearing a lot about various pieces of technology that are being created, whether it's for airplanes, someone would have an app that would show that they've been given the vaccination, or maybe in the future for concerts as a way to ensure that the people on the plane or at the concert have been vaccinated. Do you foresee, I'm just curious, do you foresee something like that being utilized in these types of communities, some piece of technology being used to ensure staff, visitors, residents sort of have an electronic ID confirming their vaccination?
Yeah, Rob, I've been hearing about that too, and you guys are the legal experts, so I don't know what the legal underpinning of the ability for an organization to do that, but I think it would be very likely that people are going to need to be able to show their vaccine status at some point in time to some entity for some reason. So I see that coming. I do.
Okay. And Rob, let me just add to that, because let's say there was a push to mandate that the visitors had a vaccine. It brings so many other issues, because what if there's some kind of medical contraindication to your vaccine? What if you have a religious reason why you don't want the vaccine? So it brings so many issues. That brings us right back to one of my first slides, which was resident rights. Residents have the right to have their families come visit. And so I think the legal issues that would be raised by that are, too many for an hour-long webinar or even a 10-hour-long webinar, to be honest with you. So,
but I do have to jump in and say that the infection control practices are so important in congregate settings. As everyone realizes, one case can multiply and spread like wildfire. And so I'm sure everyone's visitor policies are cognizant of how important that is.
Yeah, but the truth is, if we're gonna just be honest, like, we can have the policies, but you walk in and you fill out a form, maybe some people aren't completely accurate when they're filling out the form. So, one, I guess, inaccurate form could spread the virus like wildfire. So, so those are the problems that these facilities face. Okay, so I'm trying. Okay. So what about the healthcare personnel, right? And the strategies for healthcare personnel. And so I was happy to hear Dr. Coonan say before that the new polling has showed that more people are willing to take the virus. But I had looked up a poll of certified nursing assistants, of CNAs in nursing homes, and 72% of them did not want to receive the virus. And that takes us back to where we were talking before. We need to educate everyone on the virus, not the virus, on the vaccine, in order for them to feel comfortable in taking the vaccine. So, from the facility's perspective, you may want to implement a vaccine policy and be upfront and address the concerns. Have an in-service about the vaccine. Encourage people to ask questions. And if you don't know the answers to the questions, we could always reach out to the CDC, to the Department of Health, and try to get the answers to the questions. The more information I think that the employees get, the more likely they will be to take the vaccine. And ultimately, it's going to be better for everyone. You're on mute, Dr. Coonan.
Yeah, so I want to jump in because the Pfizer vaccine in particular has very, very special handling properties about the amount of time that it's okay to use it after defrosting. I would not be surprised that the pharmacy companies are going to contact the nursing homes and say, how many people are we vaccinating tomorrow, so that they can plan ahead and not waste any of this precious vaccine. And therefore, the education needs to come before that call comes, so that people respond to the facility about their willingness to take the vaccine after they've been educated and informed and their questions answered.
And I agree 100%. And that's why I think we need to be doing in-services with all of the staff so that they have the opportunity to make an informed decision. Okay. So one of the recommendations is that we, and I think Dr. Coonan spoke about this already, that we stagger the delivery of the vaccine. The last thing we want, and listen, in April and May, every nursing home had a staffing shortage, at least in the state of New York and New Jersey. We do not need to go through that again. So just in case that there are any types of side effects, we certainly should stagger the giving of the vaccines to the employees. And actually, the Department of Health is recommending a 1/3. So you give it to 1/3, and then another third, and then another third, coming down the road. That way, we're not in a situation that, 50% of our staff is not feeling well and not coming to work. Okay. So, can employers mandate that employees get the vaccine? So the answer is not under the EUA. So this is really a question for the future when there is full approval. And the answer is not completely clear. In general, I believe that the answer will be yes, if there is a legitimate business purpose. Now, obviously, in a nursing home where you're treating the most vulnerable population, I believe there will be a legitimate business purpose. So can you mandate it in the future? Not right now, perhaps, but you have to think of all of the legal ramifications that come with that. Employees that refuse, employees that have medical issues, employees that have religious reasons why they do not want the vaccine. What are going to be the consequences of non-compliance? Because if you decide after this is approved, I'm going to make all of my employees do this, and some of them refuse, what are you going to do? Are you going to fire them? Are you going to discipline them? Are you going to have them walking around in full PPE like we do for the flu vaccine? So these are all questions that have not yet been ironed out. But before you make a decision, I mean, I think your best bet is to speak to, your attorneys, your employment attorneys, because there are going to be a lot of ramifications and a lot of consequences. If you're a union shop, you're going to have to consult with the union people to see what a mandated vaccine, what that will subject, it's going to be subject to the National Labor Relations Board. So you want to talk it out before you make any decisions. Okay, so let's talk for a second about liability, right? So what is the facility's liability under workers' comp or other liability for personal injury? The truth is, this is too early. It's just too early to tell. So it's a good idea to reach out to your workers' comp carrier, to your general liability carrier, in order to see what position they're taking right now as to what is and what is not covered. What if the vaccine is improperly administered or there are errors by the pharmacy? You're going to want to know if the pharmacy, if CVS or Walgreens comes in and there's some kind of screw up with them, am I, the nursing home, going to be covered by my GL policy, my general liability policy, for whatever happens with, whatever happened with Walgreens or CVS? Okay. In general, if an employee suffers serious physical injury or death as a direct result of the COVID-19 vaccine, there is potential coverage under the Countermeasures Injury Compensation Program. That's a federal program, and it will cover serious physical injury or death, which hopefully it never comes to that. That is different than the National Vaccine Injury Compensation Policy Program, which would cover issues that arise from, I'm going to call it, this is my word, more routine vaccines given to children or to pregnant women. But there is this other federal coverage out there. Okay, so best practices, and Dr. Coonan, if you disagree with any of these, please jump in. Strongly encourage your staff to be vaccinated, and do that with a lot of education. Implement a written policy that lays out the risks and benefits and the potential job-related consequences, okay? Then the risk, and this policy, you're going to have to update it on a regular basis, because I think we're learning more on a daily basis as to the risks and the benefits. Have your staff sign on to this policy. You can also, and this has happened, this has been said by the government, you can offer incentives to your employees in order to take the vaccine. PTO, bonuses, gift cards, we could be creative. No pizza parties, because that would not adhere to our social distancing practices. So no pizza, but gift cards. And finally, by executive order from, I guess, 4 days ago, the governor suspended the requirement under the public health law and under the regulations, which requires people that are 19 years or older to consent to have their immunization information reported to the New York State Registry or the New York City Registry. So this executive order allows us, or mandates us, I should say, to report this information to the registries without consent. So that's what we have to do. DOH is supposed to be sending guidance. As of this morning, we did not have that guidance, but to be continued. And I think now we are open to questions. And Rob, I don't know if there's any questions out there.
I don't think we have any. I think the snow deterred everyone's questions today.
Okay. Well, from my behalf, I just want to thank you all for joining us, and our emails are there. So if you have any questions or need anything more, please feel free to reach out. I don't know if Dr. Coonan and Rob, if you have any parting words as well.
Dr. Coonan, after you.
I'm very pleased to talk to you today. We're in a very dynamic time right now, and thanks for the opportunity to share this with you.
And thank you for everyone for joining us. We really appreciate it.
All right. Bye, everybody. Stay safe.
Have a wonderful day.